Hello, everyone, and welcome to today's webinar, Delivering Patient-Centric Care in Assessing Mild Traumatic Brain Injury Through Novel Brain Biomarkers. I am Morgan Sterling of LabRoots, and I will be your moderator for today's event. Today's educational web seminar is presented by LabRoots and brought to you by Abbott. To learn more, visit corelaboratory.abbott. We encourage you to participate today by submitting any questions you may have during the presentation. To do so, simply type them into the Ask a Question box and click Send. We'll answer as many questions as we have time for at the end of our presentation. You may also submit any technical issues here as well, if you have trouble seeing or hearing the presentation. I'd like to now welcome our speakers, Dr. Martina Pavletić, Head of Emergency Department in Clinical Hospital Center in Rijeka in Croatia. And we also have Dr. Ksenia Musaelyan, Medical Affairs Manager, Medical and Scientific Affairs in Abbott. Dr. Musaelyan has been part of the Core Diagnostics Division at Abbott in the Neurology Medical Research Team for the last 3 years, supporting biomarker discovery for brain disorders. Dr. Musaelyan, you may now begin your presentation.
Thank you, Morgan. It's a great pleasure to be here today. Up until now, we would rarely talk about neurological conditions in the context of laboratory diagnostics and blood biomarkers. However, after decades of intensive research in brain injury biomarkers area, and thanks to the recent approval of the TBI test, the game is changing for the clinical care of the traumatic brain injury patients. But since it's a new topic for hospital laboratories, let's start with some of the basics, that is the definition of traumatic brain injury. The definition goes as this. TBI is defined as an alteration in brain function or other evidence of brain pathology caused by an external force. A rather simple and logical definition. However, once you start looking into a bit more detail, it gets a little bit more complex. How would you actually detect the alteration in brain function? Well, there are several signs that you could look out for. Could be a period of the loss of consciousness or decreased consciousness. It could be a period of a loss of memory, what's called amnesia, which can be retrograde, so to the period before the injury, or post-traumatic, so to the period after the injury. They could be also reflected in the signs of neurological deficits. This could be really varied, anything from weakness, loss of balance, change of vision, change of speech, paralysis, loss of sensation in the limbs or movement. It could be also alteration in mental states, such as confusion, disorientation, and so on. And if you think about it already, detecting some of the signs and evaluating them could really rest with the subjective evaluation of the treating physician. Traumatic brain injury is often referred to as a silent epidemic. What does it mean? Well, the numbers of TBI patients are unfortunately rising worldwide in all countries. It is currently thought that the estimated number is about 69 million per year that suffer from TBI, but this number is likely to be very much underestimated since a lot of TBI cases, especially mild, go unreported. It is the most vulnerable groups in society that are most susceptible to TBI, those older adults or over 75 years of age, and the young, very young within the first 4 years of life, as well as young adults 15 to 24 years. We often think of TBI as something that is most frequent for athletes, for sportsmen, or maybe military personnel. But in fact, the most frequent cause of TBI is a simple accidental fall from a person's height. Only secondary to that come motor vehicle accidents and road traffic accidents. Those could be some of the most severe TBIs. And only then comes head being struck by against an object, such as in sports injury or physical violence. TBI is most often classified based on severity into mild, moderate, and severe. However, this classification is not very straightforward. Back in 2004, World Health Organization identified that there were over 20 different definitions of TBI used in research literature. So they tried to do a unified effort and come up with a single definition. And the example provided here is from a definition used by the US Department of Defense, and it's frequently used in the research literature. But already some controversies start here. So this classification allows us to stratify patients by severity as they come into the clinic. But one of the factors here is the structural brain imaging, so result of some investigation that's being conducted. So this is not something that we can directly apply to the patient once they come in through the door. We first need to do this imaging. Finally, you see that some of the symptoms here, such as, again, the duration of the loss of consciousness, was it less than 30 minutes or more than 30 minutes, could be hard to estimate if, for example, there wasn't a witness present at the accident. And finally, one of the factors, and this is probably what used most commonly for the classification TBI severity, is the Glasgow Coma Scale. It's a scale which goes from 3 to 15. So anything from 13 to 15 is considered mild, 9 to 12 moderate, and anything below 9 is severe. Glasgow Coma Scale is a simple scale which was developed to identify a person's level of consciousness on coma, as the name suggests. The scale looks at the person's eye response, verbal response, and motor response. It was not developed, in fact, to stratify TBI patients, and it is not very sensitive when it comes to those on the milder end of the spectrum. So most of the TBI patients, in fact, could have a normal scale, could have a normal score. So the good news are that, in fact, most of the TBI cases are indeed mild. So up to 90% of TBI are mild. And of course, this is good. This means the patients are not severely injured. However, the term mild could be somewhat misleading, suggesting that this is something a patient could maybe quickly recover from or brush off. But this is not always the case. In fact, even mild TBI could have some long-lasting and debilitating consequences. And here we see that post-concussion syndrome, a syndrome that could affect patients' ability to return to a normal life, social activities, and even work, occurs up to 15% of cases. In fact, some of the more recent studies show that could be anything up to 60%. And then those persons who could be susceptible to repeated TBI, they are at the high risk of developing a dementia-like condition, which is called traumatic encephalopathy syndrome. However, returning back to the acute care, this is what we're focusing on today. So how is TBI assessed in the emergency department? Of course, every country would have their own national guidelines. In fact, every hospital might have their own care pathway. Here, I'm sharing an example from the British National Institute of Care Excellence Guidelines, which have been published in 2014 and are currently being updated. So there's going to be a new release soon. But this is a good example of how TBI patients could be assessed in the ED. So you see here, the first step is choosing the type of imaging. Depending on the patient age, as long as they're adult, there is a whole list of risk factors that the physician needs to assess to define if the CT scan needs to be done and how quickly it should be done. So in the top list is the risk factors which identify that the CT scan needs to be done within 1 hour. This includes Glasgow Coma Scale, less than 13 on the initial assessment, or less than 15, so anything that is not normal within the first 2 hours. Could be other symptoms, such as signs of the skull fracture, signs of the basal scan fracture, or post-traumatic seizures, neurological deficits, some that we discussed earlier, and more than one episode of vomiting. However, even if the patient doesn't have any of these, that doesn't mean that they don't need CT scan at all. They might still fall in the second category, and these are the ones who need a CT scan within 8 hours. Those could be age 65 years and older, with a history of bleeding or clotting disorders. This includes patients on blood thinning on anticoagulant medications, those with dangerous mechanism of injury, or those who had an amnesia more than 30 minutes. So you see that this is quite a long list, which in fact covers a large proportion of patients. and results in a very high number of CT scans that are currently being conducted in the ED. And you don't have to take my word for it. There is, in fact, the data. This is data from a US epidemiological study, but we know that the trends are more or less the same across the world. So among all the TBI patients, 90% of them do turn out to be mild, which is good. But among those mild patients, most of them do have a CT scan conducted once they're seen in the emergency department. Out of those, only less than 10% are in fact found to have any kind of abnormalities on the CT scan. And you might wonder why it's such an excessive practice, why so many CT scans are done, while very few of them actually find any abnormalities. Well, there is a good reason for that, and that is to make sure we do not miss a very small percentage of patients, that is less than 0.5%, that might be developing life-threatening hematomas that might require urgent transfer to surgery, neurosurgery. And indeed, delaying these patients or missing them might result in their premature death. And therefore, this practice was developed to make sure these patients are not missed. And it is working very well now. Very few of these patients are being missed, but this comes at a cost, or the cost of these excessive CT scans, which although ensure patient safety, but also result in patients having to wait in the emergency department for their scan to be done, for their report to be ready. Of course, this puts an extra pressure on the CT scanner, which might be often shared between the emergency department and the general hospital patients. And of course, it exposes patient to a dose of radiation, which increases their risk of cancer. And this is where really the biomarkers can come in to help us better select patients who are at risk of having intracranial lesions. So let's move now to talk a little bit more about the biomarkers for TBI. The research identified several proteins to be candidates for traumatic brain injury biomarkers. These are several proteins that are coming from two main types of cells in the brain, the main neuronal cells or the supportive glial cells. And they also vary in terms of which part of the cell they come from. They could be the body of the cell or the for neuron axonal parts. Two particular proteins stood out as the best candidates for TBI biomarkers. One of them is GFAP, which is coming from the glial cells, and the second one is UCHO1, which is come from body of neuronal cells. And we're going to look at them in a bit more detail right now. So the first one, glial fibrillary acidic protein, is the astrocytic protein. It is expressed in astrocytic processes. So it's a structural protein. It forms the walls of the cytoskeleton of the astrocytic proteins. It is very specific to astrocytes, which makes it a very specific brain protein, which is, of course, an excellent characteristic for a TBI marker. And importantly, it is very highly expressed in the brain. It's the second most abundant brain protein. Now, UCHO1, or ubiquitin C-terminal hydrolase L1, is the opposite, or in fact, it's a complementary to GFAP. This one comes from the neurons, and it's mostly expressed in the body of the neural cells. It doesn't form any structures. It's a signaling protein involved in the protein degradation ubiquitination cascade. It is expressed mostly in neurons. In fact, L1 is the neuronal isoform, and it is also fairly highly expressed in the brain. 5% of all neural protein is UCHO1. There is a bit of expression of this protein in other tissues such as gonads and adrenal glands, but these are not the types of tissues that are usually being affected in the case of trauma, and this protein has now been used in diagnostics of any other conditions. The biology of these biomarkers defines the timing, the kinetics of their release in the course of injury. And this is, of course, very important because depending on when the proteins are being released, they may or may not be useful at different stages of the TBI care and diagnosis. So some proteins are being released very early, within minutes to hours, while others rise later, within maybe hours to days to weeks following injury. And it is due to the timing, UCHO1 being one of those very hyperacute proteins, and GFAP being one of the acute ones, that these particular proteins were selected. So let me show you some data demonstrating this. This was a study conducted by Linda Papa et al. Back in 2016, and this study took repeated measurements from patients suffering from traumatic brain injury. So here you see UCHO1 is the one in the yellow and GFAP in black. And what you can see here is that UCHO1 is elevated from the very first blood sample. So as soon as they could take it, I think within the first 15 minutes or so from injury, and it stays elevated for a few hours and then starts declining after the first 8 hours or so. While GFAP, it's also elevated very early, and some of the, in fact, newer studies are showing that it's also elevated within the first hour of injury, but then it keeps rising and peaking only within the first day, so within the first 24 hours following injury. And in fact, it stays elevated almost up to 2 days following the injury. So thanks to this complementary kinetics, we can see that within the first 12 hours, and this is the timing when most of the TBI patients are being seen, in those with intracranial lesions, at least one of these markers would be elevated at any time. So measuring two of the biomarkers together ensures that at least one of them, whether you're seeing a patient very early after injury or lately towards the end of the first 12 hours, at least one of them would always be elevated. So this directed the intended use of the TBI test. The Lindsay TBI test combines the measurement of two markers, GFAP and UCHO1, and it is aimed at determining the need for a CT scan. So the test is used for evaluation of patients, those 18 years of age and older, presenting with suspected mild traumatic brain injury within the first 12 hours to assist in determining the need for the CT scan. So if the test turns out to be negative, then the CT scan can be ruled out. So how would this be used in practice? Basically, if the patient comes in the emergency department, then within the first 12 hours, and he's an adult, and it's within the first 12 hours from injury, it's mild TBI, then blood can be collected, both plasma and serum can be analyzed, and once the sample is loaded on the analyzer, the results would be available within the first 18 minutes. And then you're given, alongside the quantitative interpretation, also a qualitative interpretation of the results, as the test is positive or negative. So for the test to be negative, both biomarkers need to be below their respected cutoffs. And if the test is negative, then the risk of having intracranial lesions is very low, and the need for a CT scan can be ruled out. However, if one of them is on or above the cutoff, then the CT scan cannot be ruled out. The performance of the test has been demonstrated in a clinical study, which was published now several times and provided the data for the regulatory approval of this test by the FDA and other regulatory agencies. So the first time the study was published by Bazarian et al. Back in 2018, and more recently also by Bazarian et al. In 2021 in Academic Emergency Medicine Journal. And this very cohort was also used to demonstrate the performance of the Lindsay test. So this study included almost 1,900 patients, those aged 18 years or older, with mild TBI, who were seen in the hospitals, emergency departments within 12 hours from injury. This was a multi-center study, so the patients were recruited over 18 different centers in the US, Germany, and Hungary. All of them had a CT scan prescribed by the treating physician, so according to their local practice and local guidelines. And then once the biomarker levels were measured, their results were compared against the results of the CT scan. So let me show you what the results showed. So we have almost 1,800 patients, and out of those 120, so 116 plus 4, those were patients who had an intracranial lesion. So this is less than 10% in line with statistics. Out of those 120, 116 were positive on the TBI test. And this translates into very high sensitivity of the test, and 96.7%. So there were 4 patients who were negative on the TBI test. But you can see the images of the scans of these patients in the publication, and none of these patients required any type of neurosurgical intervention. They had very minimal small hematomas, and in fact, one of them had a lesion which later was identified not to be associated with the trauma at all. It was just something chronic malformation that the patient had before the trauma. Out of those patients who didn't have CT scans, 713, that is 40% of them, were detected as negative on the TBI test. So if the TBI test was used clinically in this cohort, then 40% of patients could have avoided having the CT scan. And this is a large percentage of CT scans to be avoided. So this test also have a very high negative predictive value that is 99.4%. So you can be confident that if the test is negative, then there is 99.4% chance that this patient would not have intracranial lesions on the CT scan. So this is very important parameters, of course, as this is a rule-out test. So how is the progress of the implementation of this test across hospitals in Europe? Well, the test has been approved only just over a year and a half ago. So currently, various sites across Europe are going through the process of adoption and implementation of the test. But already, French Emergency Medicine Society did recommend the GFAP and UCH1 test for the rollout of CT scans in mild traumatic brain injury patients with intermediate risk. And we are looking forward to seeing more guidelines recommending this test. So to conclude, the TBI test assay measures GFAP and UCH1's proteins in plasma or serum. These two proteins are complementary in the domain of cellular origin and importantly in the kinetics in the timing of their release following injury. The proteins are very specific to brain injury and show excellent performance for the rule out of the risk of having intracranial lesions and therefore a risk of having a CT scan. In fact, the published studies far show that potentially the clinical use of the test could help to avoid up to 40% of the CT scans currently being conducted in these patients. And this has the potential to reduce the waiting times in the emergency department and, of course, the radiation exposure of these patients. Thank you very much. This concludes my talk, and I'm ready to hand it over to Dr. Pavletić. Dr. Pavletić, it's yours.
Martina Pavletić. I'm coming from Rijeka, which in my mother tongue, Croatian language, means the river. So our city means the same as the river. So I'm coming from Rijeka. I'm head of emergency department. Also, I'm working on Department of Anesthesiology, Traumatology, Emergency Intensive Care Medicine on Faculty of Medicine in University of Rijeka. And my primary specialization is internal medicine. And after that, I also had residency program finished in the nephrology and intensive care medicine. And for 8 years, I am a head of our emergency department. So I'm coming from a very small country near Italy, Austria, on the Mediterranean Sea, south of Europe. And as you can see, our town Rijeka is here with our university hospital that is also here on this slide. So just a little introduction to know who we are and what we do. Our hospital is a regional hospital center covering 3 counties in our country, and it is the only primary hospital center in the radius of around 150 kilometers that perform 24/7 cardiac catheterization procedures, neurological, also cath lab, trauma, neurosurgical operations, and also during the COVID pandemic, we were a primary respiratory care center for all COVID critical care patients from all that 3 counties included. So we are the only hospital that has to work 24/7 for the major emergencies and all other complex patients. So also, according to that, we have a quite long tradition in emergency medicine for almost 39 years. We have Department of Emergency Medicine that is quite well organized. And from the 2012 to 2022 year, we implemented many procedures in our department, including point of care ultrasound, sedation, procedural sedations for critical care patients. We introduced and started to use non-invasive ventilation and other also modalities of ventilation, then with hemodynamics and all sorts of other things. And what was prerequisite for that was the specialization of emergency medicine that started in Croatia 2011. We, of course, then had 0 specialists, but 6 residents in emergency medicine, and we are quite proud or very proud these years that we have 22 specialists in emergency medicine and many others from other hospitals, institutions that are performing their residency program in our hospital. So just few words or some details about the department. We have in our department critical care beds, isolation beds, high dependency beds, and we have 2 mobile X-rays and also 2 X-ray measuring rooms. We would like to have also CT in our department, but the CT is something like 2 minutes walk from our department. So we are quite good connected and have a good collaboration with our colleagues in radiology. Some background also information about the numbers from 1995 to 2019. We have steady but always present increase in number of patients coming to our department. So something like from 30,000 patients 20 years ago to more than 60,000 patients nowadays. So each year 7% more patients that are coming visiting our department. I think this is something that is also seen abroad. This is not something that is only unique from Croatia or for our town. So emergency overcrowding, access block to the hospital beds, this is something well known in developed and developing countries. These are just to see the triage numbers of percentage of patients. So more than 50% of patients are in first 3 triage categories, and less than 50% of patients are in 4th and 5th categories. So quite distribution is more of critical and acute patients than in ambulatory patients. From the 2013, we have our standard operation procedure for patients that are coming for suspected head trauma, and for patients with suspected head trauma in patients with alcohol abuse. And every day we have around 3 to 5 patients with trauma, brain injury coming in our department. So more than 10 years we have our local protocol that is of course based on international protocols, that we have indications and inclusion criteria for patients that needed a CT scan for suspected TBI. Inclusion criteria for patients according to our local protocol with suspected traumatic brain injury are shown in this slide. And as you can see, the criteria are as follows. Glasgow Coma Scale less than 13. At any time after injury, Glasgow Coma Scale 13 or 14 in 2 hours after injury, suspected open or impressive skull fracture, signs and symptoms of skull base fracture, amnesia lasting more than 30 minutes after injury, or post-traumatic convulsions or focal neurological deficit. All patients that have specific injury mechanism, coagulopathy, or older than 65 years, they also have indications for a CT scan for suspected mild brain traumatic injury. So in this slide, you can see current pathway, current patient care pathway in emergency department of my hospital. And when we have patient with head injury, we first perform, of course, a Glasgow Coma Scale after the triage process, including with anamnesia and clinical evaluation of the patient. And if the patient has Glasgow Coma Scale 12 or less than that, he goes immediately to CT scan. And of course, if the CT scan is positive, then she is hospitalized. If the CT scan is negative, then it depends according to the follow-up of the patient, according to his or her clinical picture. But more or less, the patients are hospitalized due to observation and repeated CT scan. The patients with mild traumatic brain injury, that is the focus of our talk today, patients with Glasgow Coma Scale 13 to 15, if they have indication for CT scan according to our local protocol, he or she goes to CT scan. If they do not have indication for CT scan, then we discharge them home without further investigation. All patients, and it is more than 90% of them that have negative CT scan, if they need to be observed in hospital, then we admit them to the neurosurgery clinic. But if they do not have indications for that, we discharge them home. So what all those patients have in common? They might have in common traumatic brain injury, but of course, without CT scan, we can't be sure which of patients with Glasgow Coma Scale 13 to 15 really do have traumatic brain injury. So just to recap again, indications for brain CT based on clinical factors results in high frequency of negative CT scans, more than 90%. And this is really very, very difficult in emergency departments for the staff and of course for the patients also, because of the delay hours that patients have to be in our department. And only 1% of them, they really need for neurosurgical intervention. So what is the rationale of the study that we performed in our emergency department last year? That the use of neurological biomarkers in diagnostic mTBI is promising and could reduce CT scan for up to 30 to 40%. So last year, a little bit more than 8 months till now, we had a prospective observational study in our department that named the role of neurological biomarkers in brain injury diagnostics. And I will just slightly introduce my colleagues that made a lot of work and effort and enthusiasm that this study could be satisfactorily finished and that we could have results that we just have. So I introduce myself. Professor Šulcić is our professor and head of Department of Anesthesiology, Traumatology, Intensive and Emergency Medicine on our Faculty of Medicine with more than 30 years of experience, and he was twice dean of our faculty, so really a lot of experience and research. And my younger specialists and my younger colleagues that really wanted to perform this study and came to me with the idea and what we could do in our department is Dr. Ana Tancebel-Mačinković and Dr. Mate Lerga that really made a lot of work in clinical practice and in technical work how to make a study and all according to that. We had a very good collaboration with our Department of Laboratory Medicine with Vesna Šupak-Smolčić. She is specialist of laboratory medicine. and she made all the analysis of the blood test of the patient, and also statistical analysis for our study, with collaboration and good connection with the head of our laboratory diagnostic and specialist of laboratory medicine, Professor Lidija Bilić-Zuler. So it was really a good collaboration with our two departments that had a fruitful results. So the goals of our study was primary goal validation of TBI test with 2 neurological biomarkers for exclusion of TBI. I always want to accent that that we can use them only to exclude the mild traumatic brain injury. And secondary goals were reduction of unnecessary CT scan. We estimated up to 40%, and detecting patients with false negative CT results. So all patients that were admitted to our ED, that were adults more than 18 years old, within 12 hours of head injury and with Glasgow Coma Scale 13 to 15, they had inclusion criteria to enter our study. Of course, we had our ethical approval of that study, and we only recruited patients that were willing to be in our study. What we did to them was blood analysis, and results, of course, were interpreted according to the manufacturer's cutoff values. So for first one, GFAP was more than 35, and for the ubiquitin was more than 400, and it indicated a positive finding. Both markers below the cutoff value indicate a negative finding. So 1 or 2 positive were positive results, and both negative were negative results. And as I said, statistical analysis was done by our colleague and friend Vesna, and she performed using the program that is written here. So these were our results and findings. So we performed the study from the late of April to the late of July last year. We recruited 188 patients, and 149 patients had analyzable data. And as you can see in this table, the results of our study. So from the group of the patients that had that had negative biomarkers, which is really very important to accent, with negative biomarkers, none of that patient had positive CT scan. So in our results, we had a sensitivity of 100%, and negative predictive value of 100%. Of course, specificity is less, and we all know that these biomarkers can be used only to exclude brain trauma, not to detect brain trauma. So in conclusion, with our study, the combination of both biomarkers is suitable to exclude the need for CT for mild traumatic brain injury in emergency patients with, in our study, 100% negative predictive value. And because of its low specificity and diagnostic accuracy, the test should not be used to confirm the diagnosis. So I would just like to also share some of the problems, technical problems that we had performing our study. How to involve all the staff and involve all the patients, or more and more patients in the study. So in the beginning of when we had our meetings about the study design, we had staff meeting with all emergency medicine specialists, with all emergency medicine residents and others, doctors working in the ED, and with whole nurses, technician staff, because in emergency department there is always a team that is with doctors and nurses together, and we wanted really to all them to know what wanted to perform. And we also want to stress to all of them what will be the purpose of that study and what will be the benefits to all of us and, of course, to the patients with that study and with the opportunity of implementing neurological biomarkers in our everyday practice. So we also had an animation of doctors to include patients, and we did several things to do. And one of the most, I think, positive thing and positive and valuable that Mate was invented was poster with QR code on workstations. So we had in all our workstations, and this is something like 10 workstations in both of our location departments. And all doctors could just scan the barcode, and that barcode with inclusion criteria, with rationale and benefits of the study, went to one quick questionnaire that they fill up. And after that, all the results and answers from that questionnaire went to one Google table that we really 24/7 real time could follow and to see how many patients were recruited to the study, and we could know all every day the number of them. And for also the colleagues, it was easier to recruit patients in the study because it was done all the time in real life, not something after work that you have to fill up anything. So besides that, we on daily basis when needed, we also animate and with our emails and calls to all the staff to do not forget about the study. It's very important to recruit the patients. And of course, on our department's weekly meetings, we said every time how many patients we recruited and when and ask where are the problems, what can we solve out to be better in that way. So slightly we moved forward, and after 2 months we had really results. We recruited 188 patients, and we had possibility to make analysis of all our results of our patients. So we after that, of course, also had meeting to see what were the key learnings and what were the challenging using this test. And we really also realized that we have possibility of reducing unnecessary CT scan up to 40% also in our patients, that we could have faster and safer treatment of our patients with mild traumatic brain injury, that we can improve patients' flow in the ED, which is very important, and that we have potential of detecting patients with false negative CT results for the patients that can have clinical picture and that can have also positive biomarkers but negative CT results. So we were quite motivated in doing and this study and to go for implementation of neurological biomarkers in our everyday practice. So challenges were also few of them, and in the near future we also discussed and saw the potential for some other research, not just but for the research purpose of neurological biomarkers. We wanted to implement new protocol and diagnostic for patients in the group of CT negative but mild traumatic brain injury positive subgroup. We are really very interested in what is happening with that group of patients, because we can see it as a false positive but also false negative group of patients, and that perhaps that patient could have some slight minor neurological damage, which could be seen in the future. We don't know yet that. This is research ongoing. And also we can have a challenging using these tests in observation. So maybe after some, the one answer how to manage that group of patients could be new CT scan in the next 12 hours after observation, or perhaps magnetic resonance done immediately. And because of its low specificity and diagnostic accuracy, the test should not be used to confirm the diagnosis. I really like to stress it out because this is very important to not forget. So we have quite few challenges in our future. We did some work in the past 8 months, but there are also a lot of work in the future. So we applied for financial reimbursement from National Health Insurance Company in Croatia. We have public health, and we have to have reimbursement to implement anything new. So we are waiting for the answer from our health insurance company. We did it together with our National Croatian Society for Emergency Medicine, because this is very important to have support of our national society. And also we started to write national guidelines that we want to stress it out how important are neurological biomarkers, and to put them in the place that they should be in, not just local but also national protocol. So it could all departments and all hospitals in Croatia could use it in the near future. So in this slide you can see our proposed algorithm, or how to manage patients with mild traumatic brain injury in the emergency departments. So that will be in the national guidelines, and it is of course divided for, according to Glasgow Coma Scale and according to inclusion criteria, and to all patients with mild traumatic brain injury should have neurological biomarkers done, and for those that will have positive biomarkers will go to CT scan to exclude or to detect whether the patient has something in the brain or not. Of course, we can't never forget about the clinical picture and the need for observation of the patient. So if the patient has negative CT scan and if has anything in clinical picture that should be observed in the hospital, we have a local protocol that we admit them to the neurosurgery clinic. We do not observe those patients in our department because we don't have space, and we have always new patients coming to emergency department. But this is something to be discussed and to be according to local protocol solved. So our protocol is for our hospital and our region. So thank you all for listening to me, and I am open to any of your questions. Thank you.
Thank you, Dr. Musaelyan and Dr. Pavletić, for your informative presentations. We will now start the live Q&A portion of the webinar. If you do have any questions you'd like to ask, please do so now. Just click on the Ask a Question box located at the far left of your screen. We'll answer as many questions as we have time for. Let's go ahead and get started. First question is for Dr. Pavletić. Can you share key learnings on your collaboration with the laboratory and other functions in implementing this test?
Yeah, of course, I will repeat that. Thank you for your questions. Some of them I already said in my presentation. So we had, this was one first major study that we really performed in our department, that included all the staff and all the department, and we have many doctors on rotation, and it was really difficult, and we thought a lot how to not lose the patients and how to recruit all of them or many of them in our study. So I think that for the future, for the next studies, it will be much easier than this first. So and this was something that I also wanted to share, and I put it on our slide. So we learned how to use something that also pandemic brought to us, like MS Teams meetings that we really on the weekly basis, we animate all our doctors. We started to use Google tables to follow the study all the time, not just, I don't know, after 1 month, let's see what we've done. So when in that table for 2 or 3 weeks, 2 or 3 days, there were no patient recruited. So I really knew something went wrong, because every day we have 5 TBI patients. So we really, with our department of laboratory, they are really very willing to make any studies, and they are here for all of our departments in the hospital. They make analysis for all of them, not just for us, and it really makes something that we felt quite proud. And for the patients, key learning options were that patients, they were really willing to participate. That was be quite afraid of, because we thought maybe, you know, something the patient came to emergency department that had some head injury, and he's not in very serious condition for us, but for the patient, whether it's she or he, they are quite stressful and quite I don't know, sometimes afraid, and then to go to explain to her, and she want to have a blood test, and to recruit them to some study. But really, they were very willing to participate. This was something that really encouraged us to continue with the study.
Awesome, thank you. And next question is for Dr. Ksenia. How does Abbott TBI test compare to S100B used in some hospitals for CT rule-out?
Thank you. That's an excellent question. Indeed, S100B was introduced a good few years ago in some of the hospitals across Europe, especially in Scandinavian countries, for the rollout of the CT scan as well in mTBI patients. But its adoption hasn't been very wide, and there are a few reasons for that. Firstly, because S100B is a hyperacute marker, and since it is a single biomarker, it is very restricted in terms of the timing. So depending on the guidelines, it can only be used within the first 3 to 6 hours. So this is already where our test could be used in a wider group of patients, those seen within 12 hours. That's first thing. And secondly, S100B is not very specific to the brain. It's also expressed in muscles and fat and skin. And those are the kind of tissues that are often affected by extracranial traumas, orthopedic traumas that could be often present alongside the TBI. So it's not very useful in multi-trauma patients, which are many of them the TBI cases. And the TBI test that combines the specific GFAP and EPH1 proteins does not have a restriction in terms of if it's a multi-trauma or only an isolated TBI. Thank you.
Awesome, thanks. And next question for Dr. Pavletić. Where do you see the biggest impact in your ED and for the patient with this test?
Yeah, this is very important question, and this is all that these biomarkers and the study that actually perform have sense in lesson to be very quick in determining which patient really does have traumatic brain injury, which is very important to lessen the hours of stay of patients in emergency department. Because if we have, for instance, 10 patients per day, we have 5, but let's say 10, and then we know that one of them really have traumatic brain injury, and 9 of them don't have. But without those biomarkers, we don't know who of them has and hasn't. So we will be quicker I missed the words. We'll be quicker in managing our patients in emergency department. We could have a better follow-up of that patients. For the special groups of patients, like patients with alcohol abuse, which is very important, they are very difficult to manage in emergency departments in acute situations, when sometimes they are not willing to go to CT scan, and sometimes they are quite aggressive or agitated. And if we have to perform very procedural sedation in that group of patients, then it's very, very difficult, and it also the risk for managing that group of patients is very high. So this is one of the group of the patients that we can see a lot of promising opportunity for them to implement after we will implement in our everyday clinical practice neurological biomarkers, and also for the patients like pregnant women, that is not really very easy to make any CT to them, and also to lessen the stay of the patients in emergency department, to lessen the observation time, which is very important in our crowded and situations with access blocked to the hospital beds. So I think that I stressed some important, but there are also some others that we could also use them in scientific purposes, also in clinical research. But this is something different than everyday clinical practice, and we will see what will happen with some other groups of the patients, like neurological biomarker positive and CT scan negatives. But this is something that is really for the only scientific purposes that will, in near future, also I think it will be the hot topic.
Great, thank you. Looks like we have one final question. It's for Dr. Ksenia. Should patients with negative CT scan and a positive TBI test be treated differently?
That's an excellent question, yes. So how should patients be treated if they have a positive TBI test but nothing on the CT scan? So at the moment, there is no specific care pathway for these patients, and there is no specific approval of the test to be used if it's a positive result. However, there's a lot of research in this area, and some studies show that increased levels of these biomarkers could be associated with some of the micro lesions or micro contusions that could be, for example, to be seen on the MRI scan, and also that increased levels of these markers in the acute period could be associated with a high risk of developing long-term complications, conditions such as post-concussion syndrome. But yet again, the test has not been approved yet for any such use. Thank you.
Awesome. Well, thank you both for your time today and your important research. We would also like to thank LabRoots and our sponsor, Abbott, for underwriting today's educational webcast. Before we go, I'd like to thank the audience for joining us today and for their interesting questions. Questions we did not have time for today and those submitting during the on-demand period will be addressed by the speaker via the contact information you provided at the time of registration. This webcast can be viewed on demand. LabRoots will alert you via email when it's available for replay. We do encourage you to share that email with your colleagues who may have missed today's live event. Until next time, thank you so much and goodbye.
Thank you.
Thank you.